Good afternoon. I'm Caroline Talib, Executive Director of the Presidential Advisory Council on HIV/AIDS, or PACHA. Welcome to day 2 of the 82nd Full Council meeting. Our PACHA Chair, Marlene McNeese, will be here shortly. She's running from another meeting. So I'm just going to kick off with roll call and we can get started. So PACHA Chair, Marlene McNeese.
Present. I actually made it, Caroline. Thank you so much. I appreciate it. And I hail from Houston, Texas, Houston Health Department, and I serve on the EHE, Stigma, Global, and Aging committees.
Guillermo Chacon.
Guillermo Chacon, present from New York, and serve as a co-chair of the Ending the HIV Epidemic and also on the subcommittee on the stigma and disruptions. Thank you.
Philip Chan. Philip Chan.
Present.
Thank you. And if you could say where you are zooming in from today and your subcommittees.
Yes, my apologies. Phil Chan here from Brown University in Providence, Rhode Island. I am on the Ending the HIV Epidemic Subcommittee. Thank you.
Thank you. And no worries, I forgot to say it in my opening. So, Tori Cooper.
Present. I am zooming in from Atlanta, where Atlanta is hosting the first Global Black Pride in the United States. So we were super, super busy, and I am co-chair of the EHE subcommittee.
Ronnie Copeland. Ronnie Copeland. Mackenzie Copley. Mackenzie Copley. Alicia Diggs.
Good morning and afternoon, everyone. Alicia Diggs zooming in from North Carolina, UNC, Center for AIDS Research. I am a part of our Stigma and Disparities subcommittee, as well as one of the co-chairs for the HIV and Aging Long-Term and Lifetime Survivors.
Jen Cates.
Hi, everybody. Jen Cates here. Calling in from Washington, D.C. I'm at KFF, where I'm Senior Vice President and Director of Global Health and HIV Policy. And on PACHA, I am a co-chair of the Global Subcommittee. Thank you.
Paul Kawada.
Hi, I'm Paul Kawada. I'm the ED at NMAC, the National Minority AIDS Council based in Washington, D.C. I am zooming in via Montreal. And the subcommittees that I am on are all of them.
Duvia Lozano. Duvia Lozano. Tiomi Luckett.
Hello, everyone. Tiomi Luckett, calling in from Little Rock, Arkansas. I serve on the Stigma and Disparities Committee, and I also sit on the Stigma and Disruption Subcommittee.
Jesse Mylan.
Hello, I'm Jesse Mylan. I'm the President and CEO at AIDS United. I'm zooming in from my home office in Ellicott City, Maryland. Our headquarters are in Washington, D.C. And I'm the co-chair of the HIV and Aging and Long-Term and Lifetime Survivors Committee. And I also serve on the Global Committee.
Thank you. DeAndre Moore.
President DeAndre Moore here, representing, hailing from Houston, Texas. I also serve on the EHE subcommittee and the Global subcommittee, and I am excited to be here today.
Thank you. Leo Moore.
Good morning and good afternoon, everyone. Dr. Leo Moore, Medical Director for LA County Department of Public Health. I am coming to you from Los Angeles, California, and I am the co-chair of the Stigma and Disparities Committee. Happy to be here. Thank you.
Laura Platero.
Hi, everyone. Laura Platero, Executive Director at the Northwest Portland Area and Health Board in Portland, Oregon, and zooming from Portland. And I sit on the EHE and Stigma Subcommittee. Thank you.
Thank you. Kayla Quimbley. Kayla Quimbley. Natalie Sanchez.
This is Natalie calling in from Los Angeles. I'm the director of UCLA Los Angeles Family AIDS Network, and I'm on the EHE as well as the Stigma and Disparities Committees.
Patrick Sullivan.
Good morning and good afternoon. I'm Patrick Sullivan. I am a professor of epidemiology at the Rollins School of Public Health at Emory University in Atlanta, which is where I'm joining from today. And I co-chair the Global Subcommittee and serve on the EHE Subcommittee. Good to see everyone.
Jeff Taylor.
Hi, good morning, good afternoon. Jeff Taylor with the HIV and Aging Research Project Palm Springs, and I serve on the Aging Committee. Thank you.
Marvell Terry II. Hansel Tukes. Oh, I'm sorry, Marvell Terry II. Hansel Tukes. Hansel Tukes. Carol Treston.
Hi, everybody. I'm Carol Treston. I'm the Executive Director of the Association of Nurses in AIDS Care. We're a global nursing membership organization. I am zooming in from Philadelphia, where I live, and I serve on PACHA's global subcommittee and also the workforce subcommittee of the EHE committee. Thanks.
Thank you. Tafina Ward. Tafina Ward. Daryl Wheeler. Daryl Wheeler.
Daryl, yes, good afternoon. My name is Daryl Wheeler. I'm the president of the State University of New York at New Paltz, and today I'm dialing in from an outdoor space in Albany, New York, the state capital.
Thank you. And our CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment liaison, Wendy Armstrong.
Present and coming from Emory University and Grady Health System. And I am on the EHE subcommittee and the workforce work group.
And I see Rania Copeland joined. So Rania?
Hi, sorry, I'm a bit late. Rania Copeland, based out of Los Angeles. I am the CEO of Equity and Impact Solutions, a health and racial equity consulting firm, and I am the co-chair of the Stigma and Disparities Subcommittee.
Thank you. I see Mackenzie Copley as well. Mackenzie?
Yes, thank you, Caroline. Hi, everyone. Mackenzie Copland, the co-founder and CEO of One Tent Health in Washington, D.C., and I'm on the EHE subcommittee.
Thank you. And now I'm going to turn to our federal partners for roll call. So when I call your name, if you can say what agency you're with and where you're zooming in from today. Kay Hayes. Kay Hayes. I see that she is on, so I'm going to say hi for her. And she is the Deputy Assistant Secretary for Infectious Disease and Director of the HHS Office of Infectious Disease and HIV/AIDS Prevention. Tim Harrison.
Good afternoon, good morning. Tim Harrison, Principal Deputy Director of the Office of Infectious Disease and HIV/AIDS Policy, and I'm joining from Washington, D.C.
Francisco Ruiz.
Vicente, good afternoon, or good evening, actually. I'm calling in from Berlin, actually on leave, but I can't miss this party, so I'm joining. I'm glad to be here. Thank you. I'm calling from the White House.
Thank you. We're glad you're here. Adrian Shanker. Adrian Shanker. David Johnson.
Good morning, good afternoon. I'm David Johnson, Deputy Assistant Secretary for Health, and I manage the regional offices for the Office of the Assistant Secretary for Health, and in here in Washington, D.C. Good to see everyone.
Jonathan Merman. Jonathan Merman. Robin Neblett Fanfare.
Hey everyone, good afternoon, good morning, good evening. I'm Robin Neblett Fanfare calling in from CDC, Division of HIV Prevention, zooming in from Atlanta. Was not able to attend yesterday because was also at Global Black Pride. Sorry I missed you, Tori, but was able to see Jesse and share space on a panel together. Hey everyone.
Hi, Laura Cheever.
Hi, Laura Cheever, zooming in from Rockville, Maryland, the HIV/AIDS Bureau at the Health Resources and Services Administration.
Kirsten Argetta.
Hi, everyone. Yes, also in here from Rockville, Maryland, with the Bureau of Primary Health Care's Health Center Program efforts in EHE in HRSA.
Rick Haverkate.
Hello, Rick Haverkate. I'm
in the Indian Health Service, the branch chief for HIV, Hep C, and STIs, and I'm coming in from Fort Lauderdale, Florida today.
Kristen Roa, sorry. Kristen Roa.
Hello, Kristen Roja. I'm a public health advisor for HIV with SAMHSA based in Rockville, Maryland.
Deanna Finzi.
Hi, everyone. I'm Deanna Finzi, and I am the acting director of the Office of AIDS Research at the NIH. Nice to see you all.
Jessica Lee. Michelle Schreiber.
Hi, Michelle Schreiber. I'm the Deputy Director for the Center for Clinical Standards and Quality at CMS, calling in from Detroit.
Rita Hargrove.
Hi, everyone. Rita Hargrove is not able to make it today, but this is Amy Shavickas. I am the Deputy Director of the Office of HIV/AIDS Housing at HUD, zooming in from Washington, D.C.
Thank you, Amy. John Ogutumilade. Andrea Callow. Casey Knopp. Sharonda Brown.
Good afternoon, Sharonda Brown, Deputy Director of Operations for OIDP, and I'm joining you all from Rockville, Maryland.
Maureen Goodnow.
Yeah, Maureen Goodnow, Senior Advisor at NIH on detail at the Office of Infectious Disease and HIV Policy, calling in from downtown DC.
Yeah, and Tracy Carson. Thank you, and that concludes roll call. I will turn it back over to our chair, Chair Marlene McNeese.
Thank you, Caroline. And again, my apologies too for being just a beat late, but glad to join you again for PACHA's 82nd full council meeting on day 2. I thought we had a really exciting day yesterday, and our agenda was filled and expertly curated and facilitated by Drs. Jen Cates and Patrick Sullivan. So I just be remiss if I didn't give another round of applause to a great day 1 of our 82nd meeting. And I am equally excited about today, day 2. We will really kick off our conversation today with hearing a bit of a message from our colleague in the White House Office of National AIDS Policy. I'm not sure how much longer we will be able to call him new or newly appointed, but Francisco Ruiz has been appointed to this position and has, in his history, worked at the Centers for Disease Control and Prevention, and as the Senior Advisor for Program Innovation and Coordination within the Division of HIV Prevention. He played an integral role in shaping and advancing programs, the agency's engagement with community partners, and ensuring that impacted populations were part of message development and the creation of new initiatives. Before joining the federal government, he worked at my beloved NASTAD, formerly known as the National Alliance of State and Territorial AIDS Directors, collaborating extensively with health departments to address the impact of HIV among key populations, including Black, Hispanic, Latinx, and LGBTQ+ communities. His focus on engaging and working with diverse communities, his experience in public health, his commitment to addressing health disparities and inequities will continue to be of great benefit to the HIV community and those who continue to work toward ending this epidemic. I will allow him now to take the floor where he will give us a bit of his message and remarks. Francisco.
Thank you, Marlene. Good afternoon, good morning, good evening, all the above to folks. Again, I am currently out of the country, so hopefully my Wi-Fi is stable, like my heart. And so I have a few remarks I just wanted to share. You know, last we met, as you know, unfortunately I wasn't able to join yesterday, but I'm looking forward to sort of seeing the recording, looking at the notes. And so I apologize in advance if sort of some of my comments are repetitive, and I hope they're not. But you know, this last time we met in June, I was new, and I think now I feel a little bit more gray, but more sort of excited in this work. And so there's been a lot of community engagement activity that I've been participating with. I was looking and trying to sort of quantify it. I think I've been on or at over 40 webinars, meetings, and conferences since last we met. So from June 5th till now, I've been really active in trying to hear from community and hearing people, not only sort of the people, but the places of interest for this work. And so that means people with HIV, older Americans, including long-term and lifetime survivors, Black gay men, cisgender women, Latina communities, including immigrant communities, healthcare providers, researchers, gay, trans, gender diverse people, and of course also funders of the work, right? We need to know the philanthropic organizations, the private sector. And so part of that is sort of see how we could all collaborate on some of the priorities that I mentioned in June around centering science, accelerating progress, and really advancing health equity. I want to also just take time and hopefully, again, not being repetitive, we've had a lot of accomplishments since the last time we met across the government. CDC, as you know, published their doxy-PEP guidelines, and then following, a lot of our federal agencies issued guidance to grantees, making sure that, it's a good thing to have guidelines, but we need to make sure folks know about them. And so a lot of our federal partners supported the guidelines and really disseminated them. CDC also awarded approximately $400 million to 59 health departments. Also, as you probably know, recently announced availability of $7 million to support efforts to accelerate PrEP uptake focused on priority populations disproportionately affected by HIV and low PrEP prescription. And so really excited about seeing that. HRSA has done also a lot of great work around the announced $51 million for health centers to implement innovative approaches to support transition and care of people leaving incarceration, announced new policy actions to facilitate access to housing for HIV, as well as recently awarded more than $1.4 billion in Ryan HIV Awards program funding for the ADAP programs and related awards. NIH also has done a lot of great work, including the recently published guidelines, clinical guidelines on anal care screening recommendations for people with HIV. CMS has been looking at PrEP and Medicare, and so they released a fact sheet for the potential sort of anticipated change in terms of coverage from Part B to Part B. They also have issued fact sheets, updated their website, and held office hours to really make sure folks understand the nuances of this change and sort of how to folks prepare, as well as a lot of other great work that's happened across government. I just wanted to highlight some of them, obviously not exhaustive. Sort of importantly is sort of looking at the national HIV strategy. We know that efforts are underway already. A lot of our federal agencies have done and conducted listening sessions and community engagement sessions. So we received notes, and received feedback from them in terms of what they've already heard from community. So we want to build on that. We want to go back to community. We want to make sure, hey, we heard you. What else is missing? And so that sort of was part of that process. And that includes sort of the notes that we received from the PACHA meetings. PACHA has done a lot of listening sessions as well as they have their meetings. So we're taking all that information to think through the next iteration of these listening sessions for the strategy. We're also sort of in that process collaborating with Office of Infectious Diseases and HIV/AIDS policy, OIDP, who are also concurrently developing the national strategic plans for STI, hepatitis, viral hepatitis, and vaccines. And so we're doing that around, again, this endemic approach. And in building on that, we had our first listening session last week at the National Ryan White Conference. Our next one will be at USCHA. That is scheduled for September 13th from 6:30 to 7:30. So we want to invite folks to join us who are going to be at USCHA. But we also know the importance of doing opportunities and providing opportunities virtually. So we're going to be developing opportunities virtually for those who can't travel or don't have access to these conferences. And I want to flag, and I'm going to talk about it a little bit later, but I want to also mention that part of these listening sessions, we're doing them co-moderated by participants of a recent summit we had in the White House. We had a summit called Rising Leaders Summit, where we brought in approximately 54 young Black, Brown, queer leaders from around the country, and they're helping sort of lead some of these listening sessions. So again, the summit was a success, and I'll talk a little bit about that a little bit later. but how do we sort of continue that momentum and that energy, and how do we sort of pass the mic to them? And so I'm really excited to be hosting these listening sessions alongside them. I also want to mention that we will be soon in the next week or so, sort of through the Federal Register notice, providing opportunities for community members to provide their feedback online as well. And so look out for that. We'll be sort of making sure we communicate that once it goes live via HIV.gov, and that is going to be posted for 60 days. And the office is committed to language access, and so we're working to also ensure that Spanish-speaking community members have the opportunity to provide feedback. So more to come on that. And want to just really encourage PACHA members to sort of put their feedback in that sort of Federal Register, but also help us get the word out to your communities, through your organizations, through your communication channels. So when that goes live, we really want to sort of lean on you to help disseminate that opportunity. We want to sort of do a wide sort of surround sound, if you will, of sort of making sure that folks know that we are listening and we're ready to sort of take note. We also met in July, the Federal Implementation Work Group met and convened for the first time since I've been in this position. And that meeting had over 17 federal agencies and departments present. There was an opportunity to hear updates of what has happened since last they met across the government. And so that was sort of summarized in a blog that, again, HIV.gov did for us. And so I'm sure all of you are already following HIV.gov, but a little plug. I've been able to sort of lean on them to really disseminate some of the information that we've been doing around ONAP. And the next meeting is slated for this fall, so more to come on that. And we're also sort of, relating to the National HIV Strategy, we're getting ready for World AIDS Day and to release a progress report. We know the importance of telling our story, so we want to make sure that we're communicating out what are the successes, but also what are the opportunities, right? We know that we're not hitting the mark in all regards, and so what do we need to do? And we need to be transparent and really share that and communicate that out to our community members. And so we're going to look at really core components of that report. We'll be highlighting the work that the federal agencies are doing to implement the National HIV Strategy, and that is, of course, in collaboration with a lot of community-based organizations in our health departments. We're looking at a skinny report, so think espresso shot, not just sort of a café con leche. We want a sort of a nice, sort of espresso shot to really get sort of the message out there in a way that is sort of digestible, thinking about ways to do that in a way that we can sort of use social media and other ways to communicate. A lot of times we don't have the time to sort of read lengthy reports. So we're trying to get the word out. And this is sort of, again, in part as we get ready to release the next iteration of the strategy. The next few months are not going to sort of slow down. We know that we have a lot of great conferences coming up, Black in the South Summit happening right before USCHA. And then there's also the STI conference right after that. So there's a lot of great meetings happening in the next month or so. So looking forward to do that. It is actually convening that the White House is putting together, which we've named Adelante, which is sort of meaning forward-leaning, if you will, to really bring visibility and action to the recent HIV surveillance report that we saw that showed Latina communities not experiencing similar trends of decline in incidence, and specifically identifying Latina gay men as the group with the highest incidence in 2022. And so we want to sort of bring some visibility and action to that. And so we're going to be having a meeting at the White House to talk about what can we do to sort of as a family to address this epidemic among our community members. Some other upcoming engagement activities that I have in queue is sort of a listening session with focus on HIV and aging. We're doing sort of some activations around rural communities and pandemics. Having a sort of also a conversation with healthcare providers, particularly those that are serving Hispanic communities. We're also having some conversations to sort of break down the Black and Brown divide, and so having conversations of how do we come together as community, and so having with a lot of organizations who are sort of in the Black-Brown spaces to sort of bring unity in this HIV work. We're also thinking about sort of a symposium that focuses on quality of life. How do we sort of roll up our sleeves and what does that really look like? And sort of looking at, so stay tuned for that. That's probably going to be later in the fall. And then two sort of priority sort of areas that I'm thinking about for the next few months is this notion of braiding funds. I know we've talked about that in the previous PACHA, so looking at sort of having conversations with health departments, with federal partners around braiding funds. What does that look like? How do we sort of really do that? What is the sort of the resources and guidance that we need around braiding funds? And then also HIV criminalization. We know the impact that criminalization has around stigma and discrimination for people with HIV. And so what are we sort of working across government as well as with community partners in sort of elevating the conversation around HIV criminalization. So those are sort of the priorities in the next few months. I'm really looking forward to collaborating with many of you on this, on these sort of priorities. I look forward to staying in touch. And I don't know if we have time for questions, but those are sort of just high level priorities that we have moving forward the next few months.
You do. Thank you, Francisco. And just thank you again for your energy and stamina since you've come on board, hitting the ground running. And again, really catapulting us through the remainder of the year with some substantial work and opportunities for us to move the needle in progress. I definitely saw a hand up, I believe, from Guillermo. So Guillermo, if you wanted to ask a question or make a comment, now would be an appropriate time.
No, just basically echo what you just say. We're very grateful for Francisco's leadership and the support that he's generating through the different federal agencies. And also it's about all of us working together to really making sure that we close the year in a very strong way and then prepare for shaping and updating the strategy from early 2025 toward 2030. We're very proud of you, hermano. Thank you.
And I too want to just thank you again for acknowledging the dramatic data that we are now recognizing and responding to as it relates to what gaps and inequities still exist for our Hispanic brothers and sisters, and really the idea that we should be developing unified approaches where appropriate between these similar inequities in Black communities as well. So thank you for lifting that up, Francisco. We live with that reality in a state like mine in Texas, where we can't afford to leave any of our communities behind. And the idea that we do know based on the data where we are sort of at a stuck point with being able to see some of these successes. So again, just thank you. I think you're right on target and right aligned with everything that is priority for the work ahead of us. So if there's any other comment or question for Francisco, go ahead, Jesse. You're muted.
Thank you, Francisco, and thank you for taking the time to call in from overseas. It's really wonderful for you to do that. Just a quick question around resources supporting your office, because as you mount this major effort to update the strategy, I think we're all just wondering, since you don't have staff, what are the resources that are supporting you in doing that major lift, and resources supporting you just generally while you're in this role?
Thank you. And when I think about resources, I look at the screen and all the beautiful Brady Bunch boxes that I see. I think I've had many conversations with many of you, and so I continue to sort of lean on your support. A lot of my federal colleagues, CDC, NIH, SAMHSA, HRSA, they've been sort of super either behind the scenes, in front of the scenes supportive. So the other thing is, as you guys know, the Office of National AIDS Policy right now officially is me. But I also sit within the Domestic Policy Council. So I've been leaning on my colleagues in DC, as well as other offices within the White House, the Office of Public Engagement, Office of Legislative Affairs. And so I've been really trying to be resourceful. If nothing else, a lot of our community members are very resourceful. I take note from my ancestors and transcestors about how do you do that work. And so I never, oftentimes when you have these ideas, you stick them on the wall and making sure that see if they stay on the wall. But have been very blessed to be able to have many partners in this work as yourselves, as well as across the White House. And so, I think resources is always a tricky thing. And all I'll say is that I think resources are always helpful and I welcome them. So thank you for bringing that up, Jesse, now and always.
Leo, I think you can be our last commenter. Go ahead.
Awesome, thank you. So first, Francisco, thank you so much for the updates and for hitting the ground running. My question is regarding the proposed rule change for covering PrEP on Medicare Part B. As a physician, I continue to see the challenges in my clinic of being able to prescribe PrEP for those patients who are on Medicare and don't have an Advantage plan. So I'm just wondering if there are any updates regarding that proposed rule change, and if not, when we should expect those. Thank you.
Yeah, so unfortunately was not able to participate on the office hours, but I've been in communication with CMS, and I know that we have a colleague here on the call from CMS to say I welcome them to sort of speak on the issue, so I don't want to speak for them. But I know they are committed to making sure that there's been a lot of communication from community partners and healthcare providers and associations around some of the concerns. And I know they've been super responsive in that. For example, they've done several communications regarding this potential change. And they're sort of positioning, they want to make sure the community is ready and our healthcare system is ready for this change. And so even the language that's coming out more is sort of like, we're ready, get ready. And so they had office hours to really sort of speak to some of these questions. And of course, with any change, there's going to be some pain points. And so I think there's going to be a learning curve, but this is really a long-term sort of plan, right? So the immediate, we're going to have some bumps. And we need to talk about them. We need to sort of address them as we can. But this is really sort of a long-term game that I think CMS really looking at equity as regards to PrEP access, both the oral and injectable. And so I think your concerns are super valid. And I think, again, CMS has been super, like I've never seen before, really responsive to feedback, really open to having conversations with community members, really not only community members, but also our federal partners. And so I think it's beautiful to see that, and especially in a and I will be honest, I didn't have prior to this role a lot of engagement with CMS, and they've been nothing but welcoming and really sort of responsive to my questions as I learn as well the process. And so I welcome you to continue, and I'm happy to have a offline conversation with folks and sort of connect the dots with some of my CMS colleagues who have been really active in this space.
And Francisco, if I may, first of all, thank you for your comments about CMS. We're hoping to have a more finalized document and more information probably a little later in the fall. I don't have an exact date for you, but I think it should be coming out shortly. So thank you.
Thank you.
Thank you for that add-on, Dr. Schreiber. We will go directly into the next portion of our agenda that will be facilitated by two people that do not need any introduction whatsoever, but I shall do my best. Coming from the Ending the HIV Epidemic subcommittee, this panel again was curated by Tori Cooper and DeAndre Moore, who will lead us through this panel conversation. As most of us know, Tori Cooper, our very own powerhouse, and subject matter expert, has done many things in leadership in HIV, including transgender communities. I will definitely say that she's now serving at the Human Rights Campaign as their director of community engagement for the Transgender Justice Initiative, and she too has hit the ground running in that role. She focuses on economic empowerment and capacity building programs, public safety, and expanding public education campaigns. And my very own beloved DeAndre Moore from the great state of Texas has had a long and meaningful effort and career in advocacy, and most poignantly for today, to bring the U equals U discussion both to the White House and the Department of Health and Human Services. In 2022, he was named Plus Magazine's Person of the Year. He engages with various communities and organizations here in the US and around the world with an emphasis in Black and Brown communities. So between the two of these leaders on our PACHA Council, I know they will engage in a very fruitful discussion. So I will turn the floor over to you, Tori and DeAndre.
Thank you so much for that wonderful introduction. I don't even recognize myself in that, but thank you so much for that. And while you were talking, Francisco, so thank you for that also. I've realized why the opposition really fights so hard against us. It's because you and Kay Hayes and Dr. Fanfare and Dr. Levine. And I'm even going to include Dr. Cheever in that. You all represent everything and everybody that they don't want leading initiatives in this country. That's not a political, well, it is a political statement, and I said it. So I think that's really important. So thank you all for what you do, and thank you all for sharing space. So I'm Tori Cooper. You got all that introduction, and my role really today is kind of serve as a conduit. DeAndre is going to have, it's going to be most of the voice that you'll hear moderating this, but together we'll work on this. I'm going to introduce our panelists, and then we're going to get right into the discussion because we only have about 40 minutes left. So our panelists for today, and when I tell you this is a stacked group, we have AJ Scruggs, who's the CEO and Executive Director of Visible Truth 365. Lorenzo J. Ramirez, who is the founder and artistic director of Grupo Folclórico Sabor Latino Incorporated. We have Monique Carey, who works with the HIV Prevention Branch, a division of Global HIV and TB, the Center of Global Health. And we have Bruce Richmond, the founding executive director of Prevention Access Campaign. So before our panelists start, DeAndre, would you come on off of mute and talk a little bit about why this panel is so important today?
Absolutely. Thank you, Marlene. Thank you to our federal partners. And thank you to all of my colleagues here on PACHA. Greetings again from Houston, Texas. And thank you so much for your time and attention today. Today's panel is a little bit close to home for me. And today I want to make it known that I am not here as an affiliate of any organization, nor only as a PACHA member, but today I represent a community, my community, which is that of people living with HIV, which is how we got here. And the reason why this panel discussion is so important, over the years, as I began my work in this field, or I've continued to work in this field and had a place in advocacy and worked with many organizations, much of which are on this call, I have seen a shift in what I believe has gone from the focus of people living with HIV to people who are HIV negative. I have seen a shift in this committee, in our council, as we continue to have every meeting that I've been a part of since coming on as a member of PACHA that has primarily had a heavy focus on PrEP access. And it seems as though that there has been so much emphasis across organizations, across conferences, convenings, to the point that PrEP has almost taken over. We have PrEP awards, we have PrEP for All, PrEP in Black America. PrEP is everywhere, and it's needed, don't get me wrong. But I think that we are started to do a disservice to those people who are living with HIV by no longer prioritizing people living with HIV as much as we do PrEP and those who are HIV negative. Now, on this council, I am outnumbered. We have more people on this council who are HIV negative than we do who are of lived experience. And I think that could or could not have some play a part in why we see so much emphasis on PrEP and those who are HIV negative. So as we have this discussion today, as a person living with HIV, I ask that everybody who is a part of this panel and who is a part of this council come forward, and that we have open minds and open hearts to hear the science, hear the impact, and hear the stories of people living with HIV, and how crucial and important it is that we start to see an emphasis on people living with HIV and going back to prioritizing people living with HIV. Because Dr. Tony Fauci said it himself. He said that U equals U is going to be the foundation of ending the HIV epidemic. My colleagues who will present today will provide you with information around the science and the impact that it has on our communities. And I'm excited to share this space with everybody. And again, I'm really thankful that we're able to be here and have this conversation, and hope that we continue to have these productive conversations as we move forward. So if we can get started, I'm going to turn the floor over to my colleague, Monique Carey, who is the HIV Prevention Branch, who is from the HIV Prevention Branch Division of Global HIV and TB for the Center of Global Health and the Centers for Disease Control and Prevention. Monique, it's on you.
Thank you, DeAndre, for that special welcome. And I want to extend my gratitude to PACHA members for inviting me here to participate in this very important conversation about U equals U. I am thrilled to be joining you as the U equals U lead in the Division of Global HIV and TB at CDC's Global Health Center. And even more excited for the fact that I'm joining you from Bangkok, Thailand right now, where I am helping with our partners from UNAIDS and our CDC Thailand office to nationally integrate into Thailand U equals U as the national strategy for ending HIV/AIDS. I would like to share 3 main lessons that I have learned from implementing U equals U in the global space. So first, U equals U is one of the most effective yet underutilized strategies for ending the global HIV/AIDS epidemic and improving the lives of people living with HIV. Second, the global implementation and promotion of U equals U continues to dispel the misconceptions and overcoming the challenges, highlighting the very efficacy of U equals U as a strategy. And third, we possess at this point in time the necessary tools to scale and systematically assess the effectiveness of U equals U, urging us to act and implement this strategy widely. To this first point, U equals U is one of the most effective yet underutilized strategy. There is a growing body of evidence demonstrating the effectiveness of U equals U. Globally, we see data about improving the uptake of prevention services such as HIV testing, early initiation of treatment, adherence and viral suppression, importantly, reducing HIV-related stigma and discrimination and improving the well-being and quality of life of people living with HIV, improving treatment literacy, especially among the younger generations, being used as an advocacy tool to promote universal access to treatment, and challenging policies and laws that are harmful and criminalize people living with HIV. What makes U equals U so effective as an intervention is its ability to address individual and interpersonal factors such as fear around or misconceptions about HIV, assuring people that it's okay to know your status and that HIV is not a death sentence, and addressing concerns or worries about transmitting HIV to your partners or your loved ones. And last, assuring people living with HIV that they can continue to have fulfilling sexual lives, have children, and pursue whatever their life goals and aspirations may be. At the community, organizational, and policy level, U equals U addresses HIV-related stigma and discriminatory practices by raising awareness and addressing misconceptions among discordant partners, family, caretakers, and the general population that you don't need to fear transmission from people living with HIV. And in healthcare settings, promoting improved access to stigma-free HIV care and treatment services. In non-healthcare settings, for example, education, work, creating welcoming and supportive environments free from HIV-related discriminatory practices. And at the institutional level, challenging policies and laws that criminalize and discriminate against people living with HIV. So that second point, the global implementation and promotion of U equals U continue to dispel misconceptions and overcome challenges. I want to share some of the common misconceptions that I see in the global space around U equals U. One misconception is that communities will not understand U equals U, or that U equals U does not translate across different groups and cultures. The reality, though, is that U equals U was created by communities living with HIV as a simple and memorable way to raise awareness of the science supporting U equals U. U equals U has been adopted in over 105 countries and translated into approximately 20 different languages. Additionally, the science and programmatic evidence shows its effectiveness and resonance across cultures, countries, sexual orientation, gender, ethnicities, and key and vulnerable populations. Where there is concern is in the equity gaps that we see in awareness of U equals U that continue to persist among key and vulnerable populations. Multiple studies are highlighting that awareness and trust or belief in U equals U is associated with more access to care and better socioeconomic status. So where we see success in addressing these equity gaps in awareness and understanding is in our programs that we're seeing globally that implement inclusive and equitable communication strategies that focus on how to address these gaps in literacy and reach populations with no or limited access to care via virtually or in person. One of the most important factors in improving awareness and understanding of U equals U is how we communicate it. As scientists, program, and providers, we often live in the realm of technical jargon, definitions, viral load cutoffs, often really overlooking the fact that we're overloading our clients and general public with information, which hinders their understanding and it fails to realize our desired outcomes. When we communicate what U equals U means, along with why it matters, and specifically to the person receiving that message, we see higher levels of understanding and the desired behavior change. For example, instead of saying it's important to take your medication so you remain undetectable, you want to say you want to maintain your undetectable status so you do not have to fear giving HIV to your sexual partners. Another misconception is that if you tell people about U equals U, it will encourage people to engage in risky behavior. But this concern, however, is not unique to U equals U. We have seen it before with PrEP, going all the way back to birth control, the HPV vaccine. We often refer to this in the scientific literature as risk compensation. And to explain risk compensation globally, a cute story that I share people as a simple example is that if we tell people that daily brushing and flossing will prevent cavities and tooth loss, then they will eat a lot of candy or more candy than they did before they knew the information. And that's the idea behind risk compensation. However, most of the data on risk compensation do not support dramatic increases in risky behavior. Instead, people are more likely to maintain their same level of risk. So meaning someone with low condom motivation or who is unable to negotiate condom use with their partners will continue to not use condoms and use them inconsistently. The data does show, however, that awareness of U equals U is associated with higher uptake of prevention services, as I mentioned, with the general public, such as HIV testing and PrEP adherence. Among people living with HIV, awareness of U equals U is associated with better outcomes and overall well-being, including ART adherence, viral suppression, optimal sexual health, and they're more likely to share their status with others. However, we continue to see resistance in promoting access to U equals U information in our global spaces sometimes as well. Often the concern about the potential for increased risks, such as decreased condom use, is prioritized over the many benefits, as I've mentioned, of U equals U. But I think we can successfully address these concerns by having implementers provide accurate information to clients to help them make informed person-centered decisions based on their individual circumstances. And as a practice, seeing prevention messages as complementary to U equals U messages, not in conflict with each other. The third misconception is that U equals U is a one-time communication campaign and not a scalable intervention. This misconception, I believe, is one of the main ones that contributes to what I said about it being the most underutilized. The reality is that U equals U is a multi-level ongoing public health intervention. It is being implemented in healthcare and non-healthcare settings. U equals U is an integral and required component of multiple global strategies to end the epidemic, such as UNAIDS, WHO, and a required component of PEPFAR and the Global Fund. Our challenges are that efforts to scale U equal U require equal ownership, buy-in, and support from our affected communities, implementers, and our government and our policymakers. Also, systematic monitoring and evaluation are needed at all levels to improve its effectiveness and document its impact. Where we see the greatest impact of U equals U at national levels is where all stakeholders are actively engaged in developing the strategies that reflect collectively owned common goals and objectives. And also where resources, as we talk about resources, human and financial, are dedicated to support those activities, and they're aligned to those strategic plans, and they include measurable targets that we can see the impact. To my last point, we currently possess the necessary tools to scale and systematically assess the effectiveness of U equals U, urging us to act and implement this strategy widely. The increase in global awareness and implementation of U equals U has gifted us with the scientific evidence supporting U equals U, the policies and the strategies to support large-scale integration, and a detailed guide for implementation that is inclusive of an implementation framework strategic areas of intervention, a model for integration into service delivery, training and job aids for capacity building, and a framework to monitor and evaluate its impact at the local, organizational, and national levels based on this collective global evidence. At the global level, where I see the next steps for U equals U are a very exciting place. I see us in a space right now where we will continue to benefit from this growing body of data and best practices that will accelerate global access to this life-saving message and the benefits of U equals U, where we are able to assess current U equals U activities and document for the world to see its successes, challenges, and gaps, and mobilize and strategically plan with our community partners, organizational champions, and other individual partners and organizations to maximize our resources and scale the impact of U equals U. Thank you.
Thank you, Monique. I appreciate you so much. And thank you again for making time. I don't know what time it is over there for sure, but I know it's a very big time difference. So we do appreciate you. And you look fabulous as always. So thank you again for the expertise. I do have some takeaways that I'm going to share later and circle back to this, but I want to keep us moving before we get into this because I think it's going to raise some questions for us. So now we're going to move on next in our presentation to the founding executive director of the Prevention Access Campaign, otherwise known as PAC, and the founding organization of the U equals U movement, Mr. Bruce Richmond. Bruce, it's on you.
Fantastic. Thank you, DeAndre. And that was wonderful and so inspiring to go after Monique, who is, there are few people worldwide who are so dedicated to U equals U and understand the multi-level benefits of U equals U and how to communicate it as Monique. So just really grateful for your partnership and all the work that you've done and the CDC DGHT has done to bring U equals U to the world. And thank you for the introduction, my dear colleague and friend DeAndre and Tori. It is great to be here. Thank you to everybody at PACHA. So many people at this meeting were a part of this incredible movement. And I was up till 4:30 in the morning trying to figure out the slides because I didn't want to leave some people out. And then I was like, because this is like, U equals U is a love letter to so many of you, and it is a result of us coming together across so many of the boundaries that divide us and cause us to fight each other. We came together and we did this out of love. We did this because we wanted other people to be able to experience love and sex and the freedom of U equals U like we do, and not only folks that are privileged and had access to the information, but everyone. So thank you. There's so many heroes in here. I feel like I'm among friends. Can't wait for our chat later, but I'm going to move through this pretty quickly because I condensed a lot of slides to try to show you the remarkable world of U equals U, which you really can't do justice in slides, especially without the sound and everything. So there is a video I'm going to post later that you can look at, and then go deeper into the US. And so why do we need U equals U here? Why is this important? Doesn't everybody know it? What's the big deal about U equals U? People with HIV just having sex without condoms. Why is that such a big deal, right? And then what do we need to do next to realize U equals U in the US for everyone, to advance health equity, improve our lives as people with HIV, and achieve the end the epidemic goals? So first, I just want to talk about privilege. Need to acknowledge that I am a huge beneficiary of the social determinants of health and the systems that were built to maintain white supremacy in the United States. They have worked in my favor, but they have not worked in the favor of my brothers and sisters who are Black and brown and trans and of low-income backgrounds. I am a white man, cisgender, food security, income, housing, health insurance, and we cannot rest until we make sure that U equals U is available and can be an option for everyone. We can only fully celebrate that when we make that a reality, and that's why we're talking today, and I think we can get there. So first, I'm going to give a glimpse into the world of U equals U. Whoops, sorry about that. Going back. So this has just been, this is just incredible. This has been a symphony of voices around the world coming together, but really born in the USA. It grew up globally, but it did start here. And there's a story behind all of these images. I can tell you about all of these people on here. Like up at the top, on the far top left is USCA in 2017. You can see Kathy Ayers and Brian Jones. You can see on the top right, Canada, when the country of Canada signed on, the first in the world in 2018. Then you can see, let's see, marching in the streets of Uganda down at the bottom there. H equals H is in Tajikistan. To the left of H equals H is the Positive Network in Moldova. And in the middle is China, which had U equals U summer camps. I mean, it's just really incredible. And this is really about MIPA and Nothing About Us Without Us on turbo drive. I mean, communities are driving this all over the world in partnership with governments. It's really beautiful and remarkable to watch. And it really did start here with us in the United States, with the activists and the advocates coming together in 2016. And we created this consensus statement to confirm the science based on all the available evidence at the time. And then we created this video of our voices of every background demanding the truth about our bodies. And we said, tell the truth or we'll tell it for you. And we knew that HIV stigma is an emergency and continues to be an emergency. And there is no time to waste in getting this message out. So luckily, we were able to find lots of allies, from the public health officials to other activists to other countries to the mayor of DC and Michael Carfin, who you can see was in the background there, all over the world coming together to a place where we were able to have Dr. Fauci come out and say the science validates U equals U in 2017 at the US Conference on AIDS, then followed by the CDC confirming the science of U equals U using effectively no risk, but then eventually phasing out effectively. We don't need to use effectively at all. And now we have the full endorsement of U equals U from the CDC, the WHO saying zero risk now, encouraging zero risk, and is scientifically established as fact. And what's really remarkable is there are two really big points about U equals U. Is one is that it's driven by the community. You know, it's these community voices all over the world. Some of them you don't know. They're not sometimes the elected representatives of people with HIV. Sometimes they're under the radar screen. I've met them. These are incredible representatives all over the world for us. And at the same time, it's a global mandate. So it's now required as a core standard of PEPFAR since 2020. So the US government is requiring other countries to have U equals U education internationally. But we're really not doing it domestically at all. And we'll show you that later. But we're telling other countries to do it. We got to do it in the US as well. It's also been a program essential for the Global Fund since 2022. So the largest donors in the HIV response are requiring their donor countries granting to have U equals U education. It was also adopted as the marching orders of the UN in the political declaration and in the PCB report. And as Vinay Saldalda says, it's our marching order as the entire UN system, and for all member states, they need to be implementing U equals U, celebrating it, trumpeting it, and advocating about it. That's Vinay Saldana, the UNAIDS liaison to the US. We now have really strong global support to bridge that gap between the global community and the global agencies. We have the global network of people living with HIV as a core partner of ours. I'm really excited about the new leadership, the co-leadership, the feminist leadership, the transition of the U equals U movement now to the global South, really where it should be. It's a very exciting time. And then lots of activities I'm just going to show you in the last year and this year. U equals U protests in South Africa and have resulted in a national U equals U campaign. We took the stage and we actually helped the WHO with this brief, worked very closely to confirm zero risk in Brisbane. National U equals U Day in Taiwan to set the stage for criminalization efforts. Fast track cities in Cameroon marching. Young women in Namibia marching. U equals U bike rides, 200 bike rides, and tuk-tuks and motorcycles marching in through the Angkor Wat complex, and that was led by the 3 networks of people with HIV in Cambodia. Our program with Ukraine started with the REACH program, USAID 5-year funded project with PATH to train the Ukraine workforce in U equals U. Really exciting stuff. And then this Italian campaign, I just have to go quickly in interest of time, but had 10 organizations coming together to launch this really funny U equals U campaign, talking about there are 2 certainties in life. One is Leonardo da Vinci painted the Mona Lisa. The other is U equals U, is zero risk. Fun things. So we're at this great place where U equals U is backed by science. We had this global, incredible community-led movement and a global mandate, but there's these major gaps, but we can handle those gaps, as Monique was saying earlier. So why is U equals U important for our response? We'll go quickly. People don't know U equals U in the United States. They don't. And this breaks my heart that this survey of 781 people living with HIV in 2022, more than half have a lack of understanding of U equals U. That is unacceptable. We need to do more. And among the folks who don't know more, hadn't heard it from their HCPs, had challenges with adherence, and had detectable viral or unknown viral loads. We need to change this. So why is there resistance? And Monique talked about this a bit. This is globally an issue. One is just a lack of awareness about it among of U equals U in general, limited understanding of why and how should we talk about U equals U? What's the big deal with U equals U? A lack of resources. There are no funding streams. We have the biggest funders in the response funding it, but we need grant-making streams to fund U equals U specifically, and governments to be funding it, like Vietnam is funding it. And that people are unwilling to share the message because of stigma against people with HIV and those of us who live with HIV, all kinds of intersectional stigma and judgments. And then this is the big one, just resistance to change. People don't like change. They just want to do things the way they've always been doing. It's human nature. So why is this so important? And we really, really, really need to understand this. First and foremost, it's for people living with HIV, for us. It improves our quality of life and our sexual, social, and reproductive lives. And a lot of folks will say, well, what does it have to do with ending the epidemic? We need to get people tested, or we need to get people in care, or we need people to get access to treatment. Why am I talking about people with HIV having sex without condoms? Well, there's a lot of reasons. One, it reduces HIV stigma. And when you reduce HIV stigma, that's not just good for those of us with HIV, but it increases people's willingness to come in and get tested and to stay in care and engage in care. It accelerates each stages of the 4 pillars, and I'll show you how in just a moment. And it strengthens our advocacy for increasing access to HIV treatment and care. And this is really important in what we call the win-win, because it's no longer just about me as a person with HIV, it's about we. When you're investing in my health, that's good for everyone. That's not only the moral thing to do and good for my quality of life, but it also reduces new transmissions. It's the most effective way to stop the epidemic, as Dr. Fauci said. So real quickly, and you all get these slides, so don't worry. U equals U affects each one of the EHE pillars. This is not well understood. I've talked to people about it. Most people just think U equals U is about people with HIV having sex without condoms, and that should be enough, right? That should be enough of a reason to celebrate it. But it's not. There's many other reasons: diagnose, treat, prevent, respond. Lots of reasons. Now, our viral suppression rates at Ryan White are extremely high. The Ryan White program should be expanded, but the big secret is our viral suppression rates overall for all people living with HIV. This just came out, 54%. Now, when we look at this and we compare it to the rest of the world, Kenya, looking at the same measurements under 200 copies per milliliter, is at 83%. South Africa, 66. Cambodia, over 90. Asia Pacific, 6. This is crazy. Why aren't we yelling about this? Why aren't we doing better with viral suppression? We hear a lot of passion about PrEP. A lot. And PrEP is super important. And I don't want to take away, but we need people with HIV to be on treatment so we can live and not pass it on. Okay, so in South Africa, there's been lots of There's been reporting about it, but there's a relative silence in the US about our low viral suppression rates. We're one of the worst places in the world to be living with HIV and getting treatment. I'm more likely to be on treatment in a rural village in Rwanda than in the United States. And who's yelling about it? Who has our back? I hope we do, and I know folks on this panel do. They're talking about 65% in Asia Pacific is really low. Again, we're at 54% in the United States. Where are the articles about that? Where are the statements? Where's the action? We don't know. So what are the next steps? One, we need to learn from other countries like Kenya, which has this higher numbers of people with HIV than we do, fewer new infections, higher viral suppression rates, 83% by 54%. And let's take a look at how deeply engaged their work has been with U=U campaigns. They've created all these kinds of materials. This is a government sending these kinds of materials out to all 10 provinces and really deeply learning and engaging the community with our U=U National Task Force. We have a lot to learn from Vietnam and Canada as well. So the next steps, and I'm rushing, this is a longer presentation, but there's a lot here and you all get this. Next steps, we need to organize, strategize, mandate, and educate. So first, we need to re-galvanize the National Task Force, which DeAndre ran last summer, and we have funding to do that. We need to come together. We work in silos. The US, we fight each other a lot. We need to come together now, and I think we really are. We have this incredible guide that Monique authored from the CDC, in collaboration with us at PAC, on scaling up U=U, and we have U=U University, which we're launching with AIDS United and IAPAC, and the global network of people living with HIV at NMAC coming up here. And we're just beginning on that. So there's a lot to go. There's still great vision and creativity here. Our guidelines have been updated already, thanks to Maureen Goodenow back in 2019. So we can build on a lot in the US. There's some great work happening in South Carolina. We've got guidance to go forward. There's a call to action in the Lancet from 15 leaders that we can follow for what to do next. There's the multinational call to action that Admiral Loreen talked about. We don't have to go through all this, but you'll have a copy of it, of next steps that we need to take. We need to follow our own call to action to the rest of the world. What we know is U=U is proven. It's an educational foundation. It's the foundation. Just by saying U=U, all of this amazing stuff happens. We have the tools to do this. We have the mentorship. We have the leadership to make U=U a reality in the United States. So let's do it. Thank you so much.
Thank you, Bruce. And I echo some of my colleagues about your passion and all of this. And then as you see, you have a round of applause coming from so many people, so many PACHA members here. And I'm just really excited to be connected to you. And thank you for making time for this today. I know it's been a long time coming and a long time to make sure that we make this happen. And I'm really excited that we stayed steadfast and resilient to making sure that it has come to fruition. So we're going to keep things going, as I know that we are not necessarily pressed for time, but we want to make sure that we make time for our colleagues. Oh, sorry, said yes, we are. So that we make time for our colleagues for any questions that we may have. So I'm going to pass it over to Lorenzo Ramirez, the founder and artistic director of Grupo. Okay, now, Lorenzo, when you come on, you're going to have to help me with some of this. I'm going to go to Community Research Liaison, Colorado Clinic and Translational Sciences Institute. Lorenzo, you have the floor. And if you could please help me out with pronouncing the rest of this title here for Grupo.
I can do that.
I don't want to mess it up. You got to take it over for me. It's on you, Lorenzo. Thank you.
Well, I want to thank you all for inviting me to participate in this panel. The name of the organization is Grupo Folclórico Sabor Latino. We're a performing group. I do a lot of cultural work within my community. I do Mexican folkloric dance and traditional Aztec dancing. I've been doing that for many, many years. And also, but my main job is with University of Colorado Clinical and Translational Sciences Institute, or CCTSI. I work as a community research liaison in the various Latino communities throughout the Metro Denver, where there's liaisons throughout the whole state. So this, I was heavily involved in HIV work, activism from the late 80s, early 90s. I was diagnosed in 1993, so I'm a long-term survivor, 31 years now. And that was my life for many, many years. I was working with a community-based organization, Servicio de la Raza. They're very well known, not only in the Denver metro area, but statewide now. Started the first HIV program in the Latino community about 30 years ago. So that was my life for quite some time on a local, regional, and national level. Then I lost my partner unexpectedly, who was HIV negative about 10 years ago to a very aggressive form of cancer. My mother's cancer came back 4 months later. So 2013 was a terrible, terrible, challenging year for me. But I have wonderful friends and a wonderful family. And I took a break from activism for a while because I needed to heal. And I needed to make sure I was a whole person before I would go back into community. So I kind of left HIV and just got into general research around health. And that was through the university. And I also noticed there wasn't a lot of grants coming in or grant requests for HIV programming. So everything had changed during my little absence for a little while. And I always kind of got at the back of my mind, why is this happening? And one day I remember I was driving with a friend and we were listening to the news on the radio, and the CDC had finally said that, undetectable is equals untransmittable. The first time I heard that, and that they had backed that up, and I was just ready to go out and dance in the streets. And my friend was like, why are you so excited about this? I said, this is amazing. All these years, after losing so many friends and watching us community suffer in silence because of the stigma, this was really like a step in a wonderful direction that was, we kind of knew within the community, but it was official. So for me, it was really kind of a turning point in the work that I was doing and trying to get back into what I could do as a person, long-term survivor living with HIV, undetectable for many, many years, and explaining that, educating the community. Because I think even with dealing with HIV/AIDS in the early years, it was education. That was the only weapon we had to address stigma and discrimination. So here we go again, but we had laid the groundwork already with the basics. So I was really surprised. Thank you, Bruce, for that wonderful historical perspective on U equals U and what's going on around the country. Monique, amazing, amazing presentation. Like I say, I've been out of HIV for a little while now, but for me, personally, it's all about quality of life. It's all about being able to love who I love without fear. When I got back into dating, which took a long time, I found myself, and I still feel myself, doing a lot of education, which is okay. Some of the partners I've had have been HIV negative, and so I had to explain the situation beyond PrEP, and they had never heard about U equals U. And even within the positive community, I'm doing education as well within the Latino community, and which is a good fit for me, being a teacher. So I think it's a perfect time for this to be back on. I heard about it in the early years, and then it just kind of disappeared. I don't know what happened. And what I've heard from some of the history, a lot of the emphasis was on PrEP, which is great, not to take away from that at all. But those of us living with HIV, it's just been amazing to share this information, this reality that is out there. And I go back to quality of life for myself. So I'm really appreciative to be a part of this. I'll be involved as much as I can now. Within the last year, as part of my healing, I got involved with the Colorado Health Network, formerly known as the Colorado AIDS Project, which I was a board member for many, many years, way, way back. And so I'm able to have a voice. I'm doing some contract work with them and to kind of boost that particular area of their prevention messages. And I'm part of the healthy living programs for long-term survivors. So this is really good timing to really start pushing this and to start to engage community around U equals U. It's so important. This is wonderful news. This is great to be able to take this back to the community, not only the community, but the families that support us and have supported us all this time. And also each other, those of us who are living with this. to support each other, embrace each other, and to advocate for one another. So that's kind of where I am in a nutshell. And I look forward to hearing more about what we can do moving forward, especially in communities of color around U equals U. Muchas gracias. Thank you.
Thank you, Lorenzo, so much for this presentation. Well, for your thoughts and your words. I want to point out something that you said that is really just resonating with me right now. And you talked about taking a break from activism to heal. And I think that that's really big and that's really important for you to do, because a lot of us on this call are activists. And we've been doing this work for so long, and oftentimes we get so burnt out. When do we take a break to heal? And I think that it's important because it raises a question that reminds me of something. I filled out a form for the Black in the South Summit recently, and there was a question on what does joy look like? But now I want to raise a question to everybody in here. What does healing look like for you? What does that really look like? And take time to resonate with that and continue to sit with that over the next few days and just think about what does that look like and how are you practicing what that can mean? Because activism is rough. Activism is dirty. It's nasty. It pulls on us in so many different ways. And we cannot show up as our full selves if we are not also healing in these spaces as well. So we're going to keep it moving with our last, but certainly not least, AJ Scruggs, the CEO and Executive Director of Visible Truth 365. AJ, you've got the floor.
Good afternoon, and hey, everybody. Thank you for having me. My name is AJ Scruggs. My pronouns are he, they, and king. Please use them all or just use my name. I am hailing from the city of brotherly love, Philadelphia, Pennsylvania, and I am a Black trans man who is openly queer and living with HIV. U equals U. Ooh, the impact on having basic education as a Black trans man is imperative. My community is not often thought about. When it comes to these conversations, we are not often brought to the table or often asked to share our lived experience. As somebody that is living openly with HIV, I am happy to share some of my experiences. Upon my diagnosis initially, the first thing I worried about was keeping my partner safe. So I asked every question that I could to my provider. I probably was in that doctor's office for a good half an hour thereafter. I know I ran him over so many things, but being able to have that time, that conversation with my provider gave me the power and the tools for somebody that's already an activist to start to disseminate this information. I have noticed a shift from the U equals U messaging to the PrEP conversation, which I've even found myself doing that same thing, because I believe that we should be preventing HIV as a part of the national strategy, because that's in there. But it does leave out the focus of those who already have that lived experience and our partners who may not be living with HIV, for those who may be engaging in other forms of work or sex work. This might actually start to cut down on a couple of different things that actually go on in that particular area. People being willing to share their statuses in those situations where before it actually may have caused harm in that space. As an example, I have been able, and now we're gonna get a little bit personal. I've been able to have open conversations with other trans men about how they engage simply because I have the U equals U education, because I have that knowledge. And finding out more information about how they actually engage as opposed to what people perceive them to engage in their bedrooms, from providers down to community. I am trying to break down those barriers with guys like us giving said education, especially with PEP, PrEP, and TASP as a part of the narrative. Keeping treatment as prevention a part of the conversation is also still pushing the U equals U narrative while giving them other options like PEP and PrEP to go into. I believe that's all I had for the moment, but I'm so grateful just to be in the space. Thank you so much for allowing me to be here.
AJ, thank you. And I want you to know that your comments and just speaking your truth and from your perspective, that's very needed and we need to hear that. So does this council. So thank you for being open and courageous and brave enough to be here in such a space as this. To our colleagues of the council, now we're going to open up the floor for any questions that you may have. Please note that we are only going to open it up for maybe 1 to 3 questions. It looks like I have my twin brother, as he calls himself, Guillermo, wants to come on. I see Carol hand is up next in the queue for me. And so we're going to start off with you, Guillermo. You have the floor.
DeAndre, you forgot identical twin brothers.
Identical twin brothers. That's right. I just have 1 inch taller than you. That's it. We got it.
Well,
It's on you, buddy.
thank you, Monique. Thank you, Bruce. Thank you, AJ, and thank you, Lorenzo. I just really want to ask ourselves, it's more like a challenge. How can we break that 54%? It's not acceptable. We really need to take, I always believe that U equal U, and Bruce know that from the beginning when he approached us, we say yes, 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 yes. It was no question because it makes sense, right? Reduce the stigma and also empower people to really live their lives. But the other piece, the other will is to move the vehicle to end the HIV epidemic is PrEP. And right in between is viral loss suppression, making sure that everybody access to treatment and reach truly and sustain viral suppression. I think that's a challenge, more like that than a question, but really to say thank you. Your voices, your campaign, your energy really is fuel, positive and green fuel for PACHA and to the communities, but especially for people living with HIV. Thank you.
Thank you. I feel like maybe Bruce, you might want to touch on that about how we can move that percentage lower for the 54%. And when you say 54, get them off, thinking that you're talking about the 54% of people who might not be aware of U equals U. Bruce, do you want, is that what you're talking about? Guillermo, that percentage of people who don't know about U equals U, or?
No, the viral loss suppression.
Just of those who are not virally suppressed. Okay, cool. Thank you for clarification. Bruce, do you want to jump in, or Monique?
Yeah, I mean, I think, and I'd love both of us to address this, but addressing the low viral suppression rates in the United States is one is we need a task force. We also, here's one thing, ask people who's an expert in viral suppression in the US. And that they won't be able to tell you. Ask them who's an expert in PrEP, and we have PrEP organizations, we have PrEP leaders, we have PrEP committees, we have community advisory boards for long-acting PrEP. But for treatment and people with HIV, we don't know who to go to. I did a survey from folks from the CDC, HHS, everywhere. Who's the expert in viral suppression? What we need is a working group on viral suppression to understand and look at the Kaiser family, Jen Cates's work at Kaiser Family Foundation. Why are folks not virally suppressed and engaged in care, right? And we do know U equals U is one way to help. There are many ways. We have to look at housing. We have to look at substance use issues, mental health, just the basic practical logistics of getting to healthcare clinics and taking time off from work, or all the social determinants of health, the racism, homophobia, all of those things we need to be looking at. And so it's complex. But one easy thing to do, and one really easy thing to do, is educate about U equals U. Because we know the data show when people with HIV know about U equals U, we're more likely, first, we feel better about ourselves. We can have sex and love and babies and all that, but we're also more likely to get on treatment and stay on treatment and become, get our viral loads suppressed and not pass it on. So there's so much that we need to do, but we really need to attack it like an issue and really look at it like a national emergency of viral suppression in the United States. We've got to start talking that way. And I thought it was, I mean, I could keep going on and on, but we need a working group. I said that at FAP about it, and it kind of got a couple people saying that sounds great, but let's dive deep into it. U equals U is one solution, and there are a lot of solutions. U equals U can be used in a lot of different ways in our advocacy as well for access to care. So, but Monique, did you have anything to add?
I do. Bruce, I'm a scientist at heart, and so I go with the data. And when we look at where we have those really high viral suppression rates globally, We have national U equals U programs integrated into the strategies. I'm thinking Vietnam, I'm thinking Canada, I'm thinking, like these places where we have phenomenal viral suppression rates. And we see it, like you said, I go back to that point where I say U equals U has really been pigeonholed as kind of like this, message, but where we see this integration in healthcare, workplace, and all these other strategies and areas. And when I say that, people feel like overwhelmed, but I'm like, it's as simple as integrating the message of U equals U into all of the systems we already have and creating that enabling environment. It's raising awareness at that level where we see the most gains in terms of lower stigma discrimination, better outcomes, and higher viral suppression rates and lower HIV transmission. It's all the things that we want. And I think the bonus on top of that is now seeing the data showing how it is actually increasing the uptake in our prevention services and bringing people out of those places where they've been afraid to interact with healthcare because they're no longer afraid or feel that stigma. And so as far as prevention, you can then link them into things like PrEP or other, like prevention methods. And we see higher rates of adherence with that. So I feel like that is the key, is taking it out of this pigeonhole, better understanding it as a more systematic intervention. And it's really simple.
Thank you, Monique. Thank you, Bruce. Bruce, you mentioned the working group, and that kind of resonated with me because I think that we mentioned or allude to that in the recommendations that we're going to present later, and that we as a full council will take a vote on, is to provide a working group and that summit at the White House centering U equals U, which I think are great recommendations that we'll get to a little bit later as a full council. Ms. Carol, it's on you.
Hi, everyone. First of all, thank you, Bruce. Wonderful presentation, and thank you for our communication. I really want to talk, Monique, comment on some of the language that you used around how providers can deliver this message. That's my lane. I am the director of a provider organization, and it hurts me when I see how few people have been talked to or understand from their provider. They may be talked at, but they don't understand the message of U equals U because it's talked about, well, your viral load is undetectable. Well, what does that mean, right? What does that mean in common language, right? What does that mean? And what a powerful message that is. And yeah, maybe a provider mentions it once, but we all know we hear things at different times and in different places, right? So it has to be an ongoing conversation. So as a provider organization, we have supported U equals U from the very beginning, but I have to say we have not promoted the education of our providers as much as we should. And I commit right now in front of everyone here to pull that back up because it's that's our lane. There's lots of other lanes that have to happen to get this U equals U thing have the value and the focus and the attention and the funding and et cetera that it needs. But provider education is my lane, and I commit to that.
Thank you, Carol. And let me jump in real quick before we go to the next one. So much of what we're talking about when we're about U equals U really is about language. And as you said, people understanding what being undetectable means. It means that you can't transmit HIV to your sexual partners. And we're also finding out, thanks in great part to CC Colvin, that folks who have children are able to breastfeed without passing HIV to their children. So that's also wonderful. And I think a big part of that language and that the messaging has to do with how we're talking about HIV transmission as well. We're all here in great part because of the ending the HIV epidemic. And so ending the epidemic, whatever ending is, often federal government uses language such as no transmission, infections, no new infections, versus advocates who saying no new transmissions. And you think of even just the terminology around that. When you think of someone getting an infection, you think of them being victimized. And when you think of someone transmitting HIV, that takes away some of the victimhood, and it almost presents power in terms of being able to stop a transmission. And I think many of us have many providers, not us on this call, but many providers have a difficult time with that power shift that needs to happen there. Where advocates and people who are living with HIV are the ones who hold the power when it comes to U equals U. All right, who was the next question? I believe
I got Natalie, Leo, and then Rania.
All
there
right.
you go.
Thank you all to the panelists. And so I just wanted to comment. So I know I really appreciate the presentation of the comparison of undetectable of viral suppression in different countries and showing how effective Ryan White is. And so I just came back from the Ryan White conference, which also presented this wonderful data of, having higher viral suppression rates over 89%. What I see, as a agency and providers working for Ryan White programs is that people who are insured or who are ineligible don't have access to the same type of support that Ryan White provides. Have any of you guys considered, as part of the U equals U, where do we invest these dollars? Is it invested in scaling up Ryan White and removing the eligibility for people? I mean, should the eligibility just be if you're a person living with HIV? Or on the other spectrum of what I've seen is trying to get primary care providers to be prescribing HIV medication. So just want to hear some thoughts around that.
I also want to make sure that we hear from Lorenzo and AJ as well.
I don't really have any, I couldn't comment on those sorts of things, on sort of like insurance and policy stuff like that. So and I'm just coming back to the US after like 4 years out of it and really even just learning about how it works here. So I can't really comment on that, but if other folks would. But I do think we should expand Ryan White. It's fantastic. I don't know how to do it exactly, but I was so impressed with the sessions and U equals U and integrated throughout the sessions. I kept hearing it come up. So
is there anyone who would like to help or chime in on what Natalie just asked? That might be a Jesse question. I don't know. The policy folks, is that something you can allude to, Jesse, right quick?
Maybe I can add in. I can add
yes, go ahead, Ron. Yes, you can. Yes, please. Ron,
this is actually a similar, Natalie, your question is a similar question that I had. And Bruce, what you were talking about is part of like what I've been seeing over the past few months. And Monique, that I've been working in some select jurisdictions that have low rates of viral suppression to try and go in and like support those jurisdictions with trying to really kind of engage people in care in a successful way. And as we started to like dive into the literature, I was so surprised at how little was there from, churn and why people fall out of care, or not even fall, like why the systems really fail them. And I think that this idea that like U equals U is like an opportunity, but if you guys had to select, say if there's like 2 to 3 things that you think help people achieve viral suppression most, right? If you can only choose 2 of them, maybe U equals U is one, but like what are those top things that you see, particularly from like the literature, that is biggest increases people being able to kind of stay in care and ultimately achieve U equals U? What are those things? Which I think is, Natalie, what you're saying, right? Like Ryan White, we know far kind of does much better when it comes to viral suppression. We suspect it's because they provide wraparound services that, are all, it's not necessarily about the virus, it's about all these other things, all these social determinants of health, right? That impact people's ability to live and thrive with HIV. But for others who don't get to have that access, what are those things that help them? What are the couple of things that PACHA could potentially focus on?
Yeah, I'd say 3 things. First is just information. We've got to get everyone information about U equals U. They need to have information about U equals U, right? And then other things and then using U equals U in our advocacy to get housing or food security or employment. So U equals U can be used when we go to Capitol Hill and we say, we need housing or we need employment services or for people with HIV, because now that's no longer just about us, it's about everyone. When you support someone with HIV and we get we're housing or we have food security, we also we take our medication, we stay healthy, we can't pass on HIV. So it's that win-win approach that so give information about U equals U, use U equals U in your advocacy for these kinds of barriers like housing or income, food security, and employment. and then also try to get around the prejudice and the stigma and that our healthcare professionals carry by and people, other service providers, by saying, look, you need to be treating your patient. You don't need to love us, or we don't want you need to like us. We hope you do, but you've got to get us treatment because that saves our lives and contributes to ending the epidemic and a stronger economy. So kind of using it in advocacy for those barriers, and as well as making sure everyone has the information. Because U equals U doesn't do a lot if you can't take your medicine, you're in a place where you can't have a pill box with you, and you're in a hostile environment, and you're moving from home to home, and you don't have food. So you have to use it in advocacy too.
Thank you,
Monique, what
Bruce.
would you say?
Thank you, Bruce. Let's hear from AJ real quick before we go to the next question, because I think AJ had something he wanted to chime in real quick.
Thank you, Tori. Information is great, but if it does not have representation, it's not going to land. If I go into a doctor's office and it's the woman's clinic, I am not going to get treatment there as a Black trans man because I'm already feeling like, regardless of what I have going on with my body or being assigned female at birth, to get simple things like a pap smear. Like, I do not want to be sent to a woman center, and like being culturally insensitive, making referrals to people, like you have to know how to deal with your clients that you are dealing with that are living with HIV. I think, again, having that cultural competency, that inclusive language within that information. So if we're talking about reproductive care and somebody is transgender, it's not going to be called women's reproductive health. Like, having that information that is going to be palatable and received by the person that is reading it in order to access services. And then we're not even talking about people that just don't have access or know where to even access care in the first place.
That's good, AJ. So what I heard you say was deliver U equals U messaging in ways that people get it, that people understand, people hear it, and people can integrate it into their own lives.
Absolutely.
That's one of the reasons we have such a difficult time, I believe, engaging cis hetero men involved in HIV prevention in the first place, even HIV care. But that's a whole nother conversation for another time. Who was next, DeAndre, with the question? I believe Mackenzie
Leo.
and then Jesse in that order.
I had Leo first, Kay, and then Mackenzie.
Thank you. Thank you. So many thanks to DeAndre and Tori for facilitating such an amazing panel, and many thank you to the panelists as well. So I just wanted to say, AJ, many of your comments really resonated with me. Number one, that you had a provider that you were able to sit with for 30 minutes, as you said, and they were able to provide that education, and you felt comfortable asking all the questions you needed to answer, which I think is really important. So number one, just naming that we do need more providers to know about U equals U and to be able to clearly explain, right? So I think that's something that came up multiple times. And so I want to thank you for that and acknowledge that. Another thought from what you said was around combined messaging. And so I think that's important as well, that we recognize that one message may not resonate with everyone, right? So I was very curious as far as what the data is showing domestically regarding Black gay men, Black cisgender women, Latino, MSM, all the different groups. How does the U equals U messaging resonate with them from a data standpoint? And is there complementary messaging that's also being considered? Because we know that one message does not fit all. Thank you.
Bruce, do you want to jump in, or does anybody else want to jump in before I touch base on this?
Can I jump in
Okay,
there?
Monique, please.
Okay.
Please, Monique, yes.
So,
You seem all over the world.
I'm gonna feel like this is my lane as a
This
health
is your lane,
communicator
yes.
and social psychologist. Thank you for that question, Leo. I always support the core message of U equals U, but I actually frame for people a list of key messages that resonate by target audience. And I talk a lot about things like audience segmentation, but really what that means is, like, what are the key audiences that this group needs to, this needs to hear, and what resonates with them. Where those messages come from is the formative work with those groups themselves. Like we have those dialogues with, like each group and say, like, if I tell you that U equals U, like, like, what do you hear when I say that to you? Like, and why does this matter in your life? Like, what does this change? And developing. So I absolutely, the suggestion you made is that there's a core message of U equals U, but there are complementary key messages that we integrate. And like I said, that's that first part. We talk about the 3 parts of communicating U equals U, which is raising awareness. Do you know about it? 2, what does it mean? And then 3, why it matters specifically to you. Like why does it motivate change in your life or improve your life or cause you to adhere or that type of thing. So really, like, thank you for that question. And yes, that is what the data is showing, is that it is more effective as a motivator within these different populations when you pair it with these complementary messages that resonate with that group that you're delivering that message to.
That's really helpful. And just very quick before you go on to the next person, because when I think of U equals U, I really do think of centering the actual person living with HIV. So at least in my conversations that I'm having, I'm more so focused on, we want to get you undetectable so you can live a long and healthy life. And also you then are unable to transmit to others.
I just want to say I love that, Leo. That's how I typically try to frame the messaging is it's about the person living with HIV. And the added benefit is those who are HIV negative can also get benefits from this by ensuring that we are not able to transmit to our partners as well. So kudos to you, Kay.
Great. No, thank you, Tori and DeAndre. This is an incredible panel. Thank you to the presenters. I wanted to say one of the most impactful campaigns in my office was the I Am a Work of Art campaign, and that was led by Dr. Tim Harrison. I will say wherever I go and I'm talking to community, that is the one campaign that someone is going to ask me about. So for me, that is a lesson learned. I look forward to the recommendations, and this discussion has been incredibly helpful. I look forward to the recommendations because I think that is a lesson learned and we can do so much more. So I just want to say thank you. This discussion has been helpful, but it made me think about the I Am a Work of Art and how that still lives with, because it was developed with community. It wasn't something that the government did and then came, it was developed lockstep with community. And so I wanted to shout out to Dr. Harrison for leading that effort, but more to come. Thank you.
Could I jump in here real quick? Thank you. Based on the conversation, been wonderful. I love the energy, but for me, what resonated, the words were motivation. When I talk with my fellow PAWS family members, community, I use the education to motivate them to stay on their medications. It's been a great motivator. Why you should stay on your medications and stay undetectable. That education is very powerful, but it's mainly me just one-on-one with folks, but that seems to work. Give them the space to ask the questions, use my own lived experience, and really go back to the quality of life. Also, with older adults, just helping break the loneliness. There's a lot of us struggling with loneliness and disconnected from community. This is a way, being undetectable, a way of reconnecting with community. And I've seen it happen slowly but surely. But yeah, just a few words that really kind of resonated with me.
Thank you, Lorenzo. I'm going to go to Mackenzie really quickly and then Jesse, and then we're going to wrap it up after these two.
Wonderful. Thank you to all the panelists, DeAndre and Tori, for organizing this, and Bruce, your energy is explosive and infectious. I really, really appreciate it. And it's probably part of why, apart from the U equals U message being so fantastic and kind of selling itself to some extent, I think having a conductor on the train with so much passion is part of what gets the job done. So thank you. My question had to do, I had 2 things. I'm going to skip the first one about like what we can do. It bugs me that U equals U is pushed really hard internationally, but here in the US, we don't push it as hard. And I wanted to like dig into that, but we can save that for another time. Thinking about strategies, the thing that really like popped out and like shocked me during your presentation was the number of people with HIV who don't know about U equals U. Everybody needs to know about it, but it feels like a particularly like motivational and wonderful thing to know about for somebody with HIV. And so I was wondering in terms of like increasing that education, was wondering if you have any like ideas that you wanted to voice, and just something that like I thought of while we were talking. I don't even know if Pacha has the power to do this, but like even like putting a little like tiny pamphlet, not pamphlet, but like piece of paper inside of bottles of ART, prescription bottles of ART. So every patient who gets a bottle learns about ART, I think would be like extremely direct education and probably quite cost effective. And so just to like kind of help that ball get rolling, I was curious if you have any thoughts, and maybe we could do something like that.
So you didn't ask me, Mackenzie, but I'll jump in real quick if I may, just to kind of keep the conversation
Yeah,
moving.
and sorry, everyone.
There are several systems that would need to take place to do
Right,
that.
yeah.
Obviously, you'd have to get pharma on board to actually include that in there, which I can't imagine would be a difficult thing, particularly for those who don't prescribe PrEP medication. Because that's part of it. And then I think there's also, my opinion is our biggest challenge is getting providers and people who write prescriptions on the U=U train.
Yeah.
There are a lot of them who don't believe it. That's why they're not telling their clients. Because there's some people who take HIV medicines who have absolutely no idea what they take. They just take it because a provider told them to take it, and you won't die.
Yep. Bravo.
Yes. So thank you for that, Mackenzie. And yes,
Thank
we
you,
will
Mackenzie.
continue what you just said in
Yes.
future conversations. Jesse?
Yeah, thank you.
No, go ahead, DeAndre, and then
No, I was
Jesse.
gonna say a lot of these pharmaceutical companies have jumped on board and have been supporting the U=U movement and the language. So I see no hang up there. Like you said, it's just a matter of different channels and different agencies, federal agencies, I think, that will also have to approve for this to be included as well. Jesse, it's on you, and then we're gonna wrap it up out of you.
Great. Well, thank you so much. And thank you to this entire panel for these very wise and very helpful words to give us deep background around the importance of U=U. I want you to know that AIDS United is very proud to partner with the Prevention Access Campaign in mounting U=U University, and there will be an institute about it at USCHA. It will be an opportunity for the entire community to know more and to start understanding how they can do more. But I want to speak specifically to the three different buckets that I think you all have articulated that we need to be thinking about. We already know that approximately 54 to 60% of the people living with HIV in this country are virally suppressed. Are they hearing this message in their clinical appointments? The answer is not consistently, if at all. That's one bucket. The second bucket is the 40% that are not yet virally suppressed, of which approximately 35% or close to 30% are sometimes in care, but not consistently in care. How do we use U=U as a message to act as a magnet to encourage people to stay in care? Now, there may be many reasons why they cannot stay in care, but if they're not hearing this message, we know that they're not using that. We're not using that as a tool to encourage them to stay in care. And then there's the percentage of people who still do not know their status, who may very well be afraid of knowing their status because they don't know the truth of U=U. Those three buckets require, as we've heard from this panel, targeted messages for key communities and key training for clinicians. So when we look carefully later today at the recommendations from this group, look carefully at the second and third resolves, which lay out how campaigns are needed and training is needed, and a national task force on U=U to assure campaigns and training are made. It's a really beautiful recommendation. I think it's very important that you look carefully at what PACHA is being asked to do, because we now have a foundation of understanding about why it's important and what other countries are doing, and now we have the opportunity to perhaps make a big difference.
Thank you very much for that, Jesse. Yeah, that's so, gosh, we could keep this conversation going. DeAndre?
I was going to say, Jesse, I don't think that was a question, but you almost brought tears to my eyes. So thank you so much for such powerful and moving words. It's almost like hearing a president speak. So thank you so much for that. And just for information on the session that's happening at U = U University at USCHA, that will be happening Friday, September the 13th from 8 a.m. to 11 a.m. So please make sure that you make a time to stop by and hear more from myself, Monique, Bruce, and others who will be a part of that conversation. Tori, you can take us out.
Yeah, we love a good plug. That was great, DeAndre.
Good.
Very quickly, AJ has his hand raised, and then DeAndre, you're going to talk a little bit about the letter.
Yes.
And then we're going to close out, Marlene.
Okay.
Again, I just wanted to just point this out. Targeted messaging, more specifically, just I have to raise this. Please do not say the transgender community and do not have one trans man represented in that flyer. I'm so serious, y'all. It's a terrible oversight, and we're wondering why trans women are targeted as much as they are. It's because they've been on the front lines. So historically, we've been in the background. So I think it's time for us to actually be put on that same front line with them, hand in hand, side by side.
Great way to end that out. Thank you so much for that, AJ. DeAndre?
That's all that I have, Tori, for now. I appreciate everyone for being here. I just want to let you all know you all should have a copy of the resolution that I think that we are going to vote on at some point. Caroline will be able to advise me on when that's going to happen. I don't think that it's now, is it? No, it's not right now. That's great, cool.
It's going to be later this afternoon. It will be during our discussion around 4:20, and there's going to be 3 resolutions, including the U = U, and they're all posted online, and I'll put it in the chat. So
thank you. And I just want to have a moment to remind everyone to take in what we heard here today. We heard from people living with HIV. We heard from the experts. We rely on that information from our experts, the science, from Bruce, from Monique, from AJ, from Lorenzo, and myself, and Tori as well, of how important this is. And we just heard a great closeout from Jesse on why it's important that we get this resolution passed. So I ask that all of my colleagues here at PACHA do our parts to ensure that we get this on our secretary's desk so that we can continue this work and moving forward and prioritizing people living with HIV. Tori, thank you so much, and thank you to everyone for your time.
Thank you, DeAndre. I just had a couple of quick notes, and then we're going to pass the mic like DJ Cassidy did at the DNC. So ending the epidemic really means no new transmissions. And so in order to do that, people who don't have HIV don't pass HIV to each other. So I believe what we have to do is really prioritize the needs of people who are living with HIV. That's it. All right. We, folks, those of us who believe in U = messaging, a lot of times we talk a lot about sex because sex is pleasure. Sex can be fun. Sex can be work. It can be a bunch of things. Sex also can be a factor of good health. And healthy sex can be a sign of good health. And so for people who are living with HIV, it's important to talk about that because that's one of the things that many of us have in common with folks who don't have HIV. Some of us enjoy having sex. All right. We have to also, we didn't really get into the mental health and stigma part. We talked about stigma a little bit, but I heard Lorenzo kind of talk about it a little, and I heard folks allude to it. But we have to also, I believe, make sure that we're educating people around the positive impacts of mental health and stigma reduction when we're talking about, when we're presenting U = U messaging. There are very few things that validate a person's existence to say, number one, you're not toxic. Number one, you're not going to die from HIV. Number two, number three, number four, somebody can love you and they don't have to have HIV to do that. I also think, and Lorenzo did talk about this, some people forget that people who are living with HIV don't just have relations, as my grandmother would say, with people who have HIV. There are folks who are having all kinds of different relations and relationships. And so one of the most powerful tools for navigating those relationships is making sure that U = U is not just branded and it's not just messaging, but it becomes a part of people's lives and part of people's relationships and part of people's healthcare. So with all of that being said, let's give a warm virtual round of applause to all of our panelists. This was dynamic. This is amazing. We could do this for hours. Thank you so much for that inbox. I appreciate that. And so now we're going to hand it back over to Chloe, Caroline, Marlene.
Yes, thank you so much. And I was not joking. Today was going to be equally invigorating and exciting as day one. So I can't say enough. We can talk for many full council meetings, and likely we'll have many additional future council meetings dedicated to U equals U and prioritization of people living with HIV. So thank you for you, DeAndre and Tori, for lifting that up back to council members' ears. I don't think anyone around this table is in disagreement with that. We will need to take a break. We are well over time, but I do believe that we all need 5 minutes. If I can encourage everyone to come back promptly at 3. I think we might be able to manage a way to get us back on schedule. I did not want to disrupt the flow of energy that was taking place. We needed to have that conversation. But yes, let's go ahead and take a 5-minute break, come back right at 3 o'clock. Thank you, everybody.
Produced by the U.S. Department of Health and Human Services.